Before your presentation starts, I'd like to take a few moments to introduce you to the City of London Dental School. We're a private postgraduate dental school based in London and run from our college facility at Southgate. Here we offer a number of various programs, both short and degree programs. At present, we offer 6 MSc titles validated by the University of Bolton. These include clinical dentistry, orthodontics, periodontology, pulpal therapy and endodontics, restorative and aesthetic dentistry, and the specialist practice of restorative aesthetic dentistry combined with implantology. These are delivered from our state-of-the-art teaching facilities, and to be introduced shortly are 3 more new titles. We're also introducing the MSc in the specialist clinical practice of aesthetic non-surgical interventions. This is to do with facial cosmetics. The MSc in the specialist practice of computer-guided implantology. This is implantology taught from a digital perspective. Also a combined MSc of restorative aesthetic dentistry with implantology. These programs are all taught from our laboratories where hand-on experience is required, where delegates get the opportunity to use the latest digital equipment, printing materials, scanners, and also to practice prep techniques on phantoms. Our short programs are in topics such as implantology, restorative, and orthodontics. These programs normally last anywhere between 4 to 12 months. We also offer clinical internships in the UK and the UAE, where delegates get to treat patients directly. In addition to this, we offer diploma and certificate programs. These programs are at HE level 7, so they're university certificates, which means that they can be used towards MSc programs, not just MSc programs that are offered by the City of London, but also other programs. So thank you for sparing the time to listen to this presentation. If you want any more information, then please contact us at info@cityoflondondentalschool.co.uk. I hope you enjoy your presentation.
Thank you very much, Stuart, and thank you to the City of London Dental School for inviting me to speak today. It's a great honour to do so, and I hope that the information that we're going to share with you today will help you understand the technology of intraoral scanning, help you to make decision making around buying these pieces of equipment if you do decide to go ahead with it. Obviously, cross-infection control is really topical right now for us all. We're all looking at our SOPs, and intraoral scanning is one way to reduce digital workflows as well, the risk of cross-infection between the practice and the lab with their traditional impression taking. My name's Ed Attenborough. I've got a lab in Nottingham that's, as Stuart said, founded over 100 years ago. It was 1913. And we started our digital journey back in 2000 with the UK's first CAD/CAM production centre. And we've seen a lot of changes come and go over the last 20 years. So today I'm going to share with you some of those experiences, and hopefully we'll be able to take forward that. So here's the overview of what's planned for today. We're going to look at how optical scanning works, the technology. We're going to take a little step back and look at desktop scanners first. And for those that attended the digital dentistry introduction lecture last week, there'll be the first 3 or 4 slides will be common to that, just to bring all of the delegates today onto the same page, so to speak. We'll then have a brief overview of a selection of scanners. Now, I don't have any particular bias. We do offer intraoral scanners ourselves. But what I want to do today is try and stay technology and brand neutral and look at the relative merits of each different scanning technology to give you a good grounding and an unbiased overview. So today isn't a sales pitch of any sort. So hopefully you'll get some idea in the outcomes of this about what to look for in buying a scanner. And then we'll look at CAD and chairside versus lab and have a conversation around that. We'll then look at scanning techniques and how to get the best out of your intraoral scanner. We'll look at some common issues that most scanners have in one way or another, and how to overcome those. And then we'll have a summary. The total duration today is about 1.5 hours. It might be slightly less, it might be slightly more, but hopefully we'll get through the bulk of it in the time allotted. So first thing to look at is the actual scanning technology itself. And here I'm showing desktop scanners, and the scanner top left was what we started with back in 2000. It's an optical scanning arrangement. And the way it works, you can see in the bottom left here, a laser beam projected on a die, and that laser beam casts a profile on the die, and then that profile is observed by two CCD cameras, a stereoscopic pair of cameras, looking from slightly different viewpoints at that profile, just in the same way that our eyes look at an object from two different profiles, and then our brains compute the point in space from the stereoscopic image. So does the digital scanner do the same process? Basically, the two different profiles have slightly different shapes, and using triangulation, the software is able to calculate back to a 3D point in space. The die is then rotated around and another image is taken, and so on through 360 degrees until you've got a full set of profiles of the die. And then the software merges all of that point cloud data together to form something called a triangle mesh, or STL file. STL standing for stereolithography. It comes from the original stereolithography 3D printing technologies that were developed about 20 years ago. So that's where scanners were 20 years ago. Bottom right, you can see a lab scanner today. Obviously, you can now get top right a lot more dies in the scanner, but the same principles apply. You've got a projected laser beam on a die captured by a stereoscopic pair of cameras. Excuse me. So scanners have moved on, lab scanners have moved on. Back in 2000, the one top left you can see was a 3-axis scanner, and now bottom right you're looking at a 5-axis scanner with much faster data acquisition. As well as laser scanning, we have something called structured light scanning, and this was the next evolution of the technology, the optical scanning technology. And basically what happens here is that a DLP light projector, the same kind of device that you find in your PowerPoint projector, projects a barcode pattern or a known pattern on the object that's to be scanned. The advantage of this technique is that obviously we're capturing lots of profiles in one position of the scanning gimbal, so the data acquisition rate is faster. And obviously we can, with the projector, we can change the patterns that are projected and do some interesting algorithms about improving the resolution of the data doing that. The disadvantage of this is that the DLP projector has a certain depth of field, as you'll know, with a PowerPoint projector, depending on where the projector's in relation to the screen, you have to focus it, and it only has a certain depth of field. So the projected pattern onto the object that's being scanned is only in focus within a certain window or depth of field. And that's important because, of course, it will affect the measurement accuracy. And when we come to talk about intraoral scanning, obviously the position of the wand with respect to the tooth or prep. The other aspect with white light scanning is that obviously white light is multiple wavelength. And as the white light passes through the optics of the scanner, be it the desktop scanner or the intraoral scanner, it diffracts. Each wavelength of light diffracts to a different extent, just in the same way that you see the rainbow effect through a prism. Now, this causes in itself a measurement inaccuracy called chromatic aberration, and that now has been overcome more recently by using monochromatic light, typically blue light, to scan, so that you're not getting this rainbow effect through the optics. However, if you want to scan in color, obviously you need to scan at different wavelengths. So we see scanners today that merge the two. They'll scan an accurate scan in monochromatic blue light, and then they will quickly do an overlay color scan in white light to create a composite image for the intraoral scan. So those are the technologies that are used in desktop scanners, and that's where the technology was developed and then miniaturized to be used in intraoral scanners. So we'll now go on to have a brief overview of a selection of scanners and compare and contrast their technologies. As I say, once again, no particular sales pitch here. We're just going to look at some of the leading brands of scanner and have a look at their different merits. So here's a selection. Obviously, CEREC was very early on the scene, Sirona, Dentsply now. The CEREC machine first came out in 1985, I think, so it was definitely first to market. And initially when the systems came out, they were closed format. So that means that the manufacturers were trying to tie the clients into the users into a particular workflow. That remained the status quo up until about 2007, where people started talking about open systems. And by open systems, they mean file formats that can be exported and used in other systems, so that you're not just locked into scanning on a CEREC and milling on a CEREC. You can use your CEREC wand for scanning and exporting to other manufacturing processes. So that was the sort of groundbreaking moment where systems became open. And CEREC, of course, has become open now, and you can output the file format in STL, the triangle format that represents the 3D object, the prep or the tooth. And other brands such as Itero have also become open. Itero now has a restorative workflow as well as an orthodontic workflow. The 3M technologies all went open. 3Shape went open. They still have their proprietary formats, but they all allow you to export the files, usually through the cloud by uploading your scan files into a portal. So we've moved on a lot in 20 years, and the technology has become open and the files interchangeable. It's worth talking a little bit at this point about file format. And at the moment, as I say, the prevailing file format is stereo STL, and that basically takes the point cloud of recordings in 3D space and maps them to a triangle mesh that represents the surface of the object. And the STL file format is quite clever, because where there's more anatomy and more detail, you'll have more triangles, and where the anatomy is smoother, you'll have less triangles. So it's almost like a 3D zip file format as well, because it only includes triangle data where it's needed, and where less data is needed, it has less triangles. So STL now is the open file format. Its limitation is that it only represents the surface of the object that's been scanned. It doesn't necessarily represent all of the internal structure, but we'll come on to talk about that. So you've got a range of scanners here. You've got the Itero, as you can see. You've got 3Shape, and you've got Trios. So lots of different technologies that we're going to quickly whiz through today, and we have got quite a bit to get through. So forgive me if we go at quite a pace. The first one we're going to look at is the Itero. This technology was launched a number of years ago and was principally used initially, as you'll all know, with Align for the Invisalign aligning technology. The current and latest incarnation is iTero Element 5D, which is available in a cart form, as we've just shown, or in a plug-in USB desktop form that can be used with a laptop. There is some conversation about laptop versus cart, and I think the practicalities of using a laptop, it is quite attractive to use a laptop, but actually when you get down to it chair side, it does present some challenges. The laptop's got to be put on a surface, the cables got to stretch from the laptop to the chair. That can provide a hazard. If somebody walks across that area, they can pull the cable out of the laptop. And of course, again, with COVID-19, keeping the laptop clean is going to be a challenge. So merits and drawbacks to using laptop versus cart, but both formats are available, so you can take your choice. It uses the parallel confocal laser scanning technique, similar to the one that I described in the first slide. The handpiece weighs around 500 grams. It uses near infrared imaging as well as optical wavelength, and I really like that because near infrared is able to penetrate soft tissue and to a certain depth within the tooth structure, which gives us an extra dimension in our recording. Typically, it takes around 60 seconds for a full arch scan. And again, it's an open workflow. So you get two workflows with this technology. You get one for orthodontic, which is closed via the Align system. And then they have a fully open restorative workflow where you can export an STL file to be used with any local lab or production center, or indeed with chairside CAD and milling. One of the things to be aware of is that, and we'll come on to talk about this later on in the presentation, is that as intraoral scanners record data, obviously they might get slight holes, areas of data that they've missed, and sometimes this data is repaired chairside. Indeed, with iTero for the orthodontic workflow, it is repaired in the software chairside. But sometimes, particularly for higher resolution scan applications in advanced crown and bridge implant restorations, implant-borne restorations, you might need a higher resolution of data to sort of 10 to 15 micron accuracy. And in this case, the data gets uploaded from the unit into the cloud. And as far as the client's concerned, that's it, their job's done. But as a lab, we don't actually see that data immediately. Sometimes it can take up to a couple of days for us to be able to download it. We can see that you've uploaded it, but we aren't allowed to download it straight away. And the reason is that the data is being worked on in a data bureau to clean the data, to stitch the data, to remove artifact, and to make it suitable for restorative purposes. So data processing is still an important part and an important consideration with intraoral scanning, because the final data set that you use has been through a data cleansing and processing technique, whichever scanner you use, which means there's been some interpolation of the data to allow for holes in the recording. And wherever you have interpolation of data, you have a potential inaccuracy, and that's not unique to iTero. That's the same for all the intraoral scanners, whether they stitch and repair the data real-time chairside, or whether it's stitched and repaired offline by a bureau. There's going to be a certain measurement uncertainty introduced by that process, and it's important to remember that. So this shows the cart technology from a few years ago. The handpiece has moved on quite a lot since that full photo was shown on the right there. And it really, I show this slide to show how quickly the technology is moving, and you know how much the handpieces are miniaturized now. And it is worth bearing in mind that now we're at a point where I think the hardware is ready to use. You know, we won't see massive leaps in the hardware now. It's mostly going to be in the software. So if you were holding back and thinking, is now the time or not, you know, you don't want a piece of hardware that's quite expensive to be obsolete within a few years. I think now is the time from a hardware point of view. And the software is somewhat of a moving feast. It's still very rapidly evolving, but that can always be uploaded or downloaded with updates. So we've got here a little video that I'm going to show, which is quite nice, of the ITERO process. Hopefully I'm going to get that up here. Hopefully you'll see it.
Imagine a platform that propels your practice into new dimensions. A platform that allows you to see beyond the current spectrum of what's possible for patient engagement and digital workflow. Hi, I'm ITERO Element 5D, and I add a new dimension to your practice. With one integrated scan, I provide an array of powerful visualization capabilities at your fingertips. I provide you powerful tools to aid in your diagnostic, restorative, and orthodontic workflows. I'm the first integrated dental imaging system that simultaneously records 3D, intraoral color, and near-infrared images, and enables comparison over time using ITERO time-lapse. NIRI helps you see your patient's internal tooth structure to aid in detecting and monitoring the progression of proximal caries from multiple angles. My built-in intraoral camera pairs with NIRI technology to take clear, precise images, giving you a new level of visualization. Rotate the 3D model and watch as I match the NIRI images and intraoral images with the angle of the scan in real time. Without harmful radiation, you can scan patients at every visit for comprehensive care. My software also includes ITERO exclusive applications like the Invisalign Outcome Simulator, Invisalign Progress Assessment, and ITERO time-lapse technology. I help you elevate your digital workflow, engage patients with easy-to-understand visuals that show them what you see, and set your practice apart with cutting-edge visualization technology. In a single scan, I help you visualize a new spectrum of dental care, beyond what the eye can see. Imagine a platform.
Okay, so there's a view of the ITERO. I should say the other point that I'll come on to talk about a little bit later on is diagnostic capabilities, and I think that's quite an important aspect of a number of the different scanning technologies. The next handset that we're going to look at is Medit. This is again a structured light scanner rather than the confocal laser scanner. So this is using the projected light technology. Weighs around 276 grams, slightly smaller handpiece than the ITERO, captures a full arch in 60 seconds and is an open workflow. The difference with the Medit is that it's primarily a data capture or impressioning device, and then you have to marry that with third-party software. That was and is still available from a number of different vendors, the open format software. And obviously Align have purchased one of those brands of software. So it'll be interesting to see how the CAD landscape evolves, but we'll come to talk about that a bit later on. But again, the Medit system is a fully open wand and scanner. Trios from 3Shape is probably one of the market leading brands at the moment. It uses structured light again, so the same scanning technology as the Medit, a little bit heavier at 345 grams. 25 seconds full arch scan quoted. Now, we have to be a little bit careful about, with all of the brands of scanners, about quoted scanning time and resolution, because most scanners have a demo mode, and the demo mode is lower resolution than the high resolution scanning mode. So this isn't specific to just Trios. We see it across quite a few of the scanners. So when you're having a demo of a scanner, I would always make sure that it's in the full high resolution scanning mode. And I would always try and have the scanner yourself in your own hands, scanning a patient in the chair. It's the only way really to get a feel for the technology and how usable it is. Again, Trios is from 3Shape is a fully open workflow, outputting an STL file format. And 3Shape, as you'll well know, have their own CAD software, both lab and chairside, and that's a whole suite of software and integrated workflows alongside it. They are open. They have the 3Shape Connect portal, so you can upload the files to that portal, and independent third-party labs can download those files and use them, as indeed we do, or you can mill chairside. So nice technology, Trios, very popular. PrimeScan by Dentsply was the evolution of the Sirona system. Again, this is using structured light, similar sized handpiece, slightly heavier at 524 grams, and takes around 60 seconds for a full out scan. Again, with an open workflow. So PrimeScan can be used chairside with a milling unit in a native file format, or it can be used in an open file format uploaded through CEREC Connect for third parties to use. So quite a nice system, and a long lineage and provenance to it from the original CEREC systems back in the 1980s. Emerald from Planmeca is again a projected light system. It uses red, green and blue lasers to project a triangulation pattern on the object. So this is the other scanning format, but with different wavelength lasers. It weighs 229 grams, so it's very light. It's quick, 30 seconds full arch scan, and an open workflow. Planmeca, who produced the Emerald, have a range of chairside solutions, including milling and CBCT scanning, and they have their own workflow environment called Romexis, which includes CAD software and CAM software for milling. So a very well integrated chairside system that's also able to be used in an open way to export data, and again can do full color scans, as can, it should be said, the Trios and the iTero and the Medit. Carestream CS3700, generation 3 now. They started off with the 3500 about 5 years ago, and then the 36, and now the 3700. Using structured light, again, it's projecting the barcode pattern, weighs 316 grams, takes 60 seconds to do a full arch scan, and is an open workflow. Carestream have, again, a bit like Romexis, their own CS software environment, which links in with all of their other data capture devices like their CBCT units, and they also have their own CAD in there. So again, a nicely integrated environment, which is also able to talk to open format systems. Dental Wings, part of the Straumann Group now, produce a Virtuo Vivo. This is a very new wand, and quite an exciting one. As you'll see, I haven't put a scale here of all the wands side by side, but the form factor of this is significantly less in diameter and length to the other wands. It has a removable tip, as do the others, for autoclaving. It uses blue laser multi-scan imaging technology, so it gets across the gets over the color aberration issue. 30 seconds for a full arch scan. It can also do full color scans, and is an open workflow. The Virtuo Vivo is available in either cart form or pod form on a USB that connects to a laptop. So a couple of options there as well with that system. You can see how compact the handpiece is here, and how you can remove and interchange the tips. The way these devices work, all of these devices, is they work on a periscope basis. So at the tip here, you have a mirror at 45 degrees, and the projector, either the laser or the DLP light projector, is based in the handle here, and it projects light down the axis of the wand. It's reflected on the mirror and then onto the object to be scanned, which reflects the light back up into the mirror, down the axis of the wand, and a pair of stereoscopic CCD cameras within the handle of the wand capture that light. So all of the scanners that we're seeing now on the market have converged on a similar technology, although some use structured light and some use laser light, and some use video capture, and some use still frame capture as you're moving along, but they're all based on similar technologies. In having a mirror here at 45 degrees, obviously that could fog intraorally, so most of them have a heated mirror here to prevent that happening. And we can see here a completely integrated workflow, again with the Straumann Virtuo Vivo system. You can have the CARES visual chairside CAD software for doing designs. You can use co-diagnostics, which we're going to look at very quickly a bit later on, for image-guided surgery, merging with CBCT to do implant planning. You can do orthodontics, and you can do smile design products and services as well. So really nice integrated environment based around the Legacy Dental Wings suite of software, which is well proven and tested. Obviously, 3Shape Move is a very recent innovation on the market. This comes in a cart format with a touch screen on a flexible arm, and the wand just attached to the side there with a USB port for easy scan. So the Trios 4 here we're looking at can do all kinds of different things. You can do diagnostics. We have smart tips that can be interchanged in seconds, and it does also have an infrared facility so that you can detect caries amongst other things. So a lot of the chairside softwares that we're seeing now have got artificial intelligence or AI built into them, and they're able to interpret the images, not just for doing outcome simulation, treatment simulation, as in the case of iTero, but also caries detection. And indeed, iTero offers a similar technology as well now. So I think we're going to see the scope of indication for intraoral scanning only increase over time with the advancement in software, so that the scanners are also able to offer immediate feedback diagnostic facilities. And this gives you some of the options with Trios here. Again, as you can see, just to summarize, nice and flexible. You've got wands, either wired or wireless. You can have a pod attached to a laptop. You can have the Move, or you can have the card. So a nice range of options there. Launca, a new one coming on the market, just about to be launched. Structured light, 60 seconds full arch scan, and an open workflow. So I think there are technologies coming both from the east and the west now, and I mentioned this one because I think the price point for the technologies will be driven quite fast by competition now. So there's a very brief overview of scanners and some of the leading brands on the market. Just want to talk very quickly about what to look for when buying a scanner. Well, the first thing to ask yourself is, what do you want to do with the scanner? Is its primary indication ortho, or is it restorative, or is it both? And that will take you down certain different workflows. Obviously, speed of scanning is important, but as long as the speed of scanning is commensurate with the time it would have taken you to take an impression or less, then I would consider that more than adequate. More importantly is ease of use, comfort of use, and accuracy of scan. So I think these days we need to be looking, all systems without doubt, of course, should be open. They should be easily held and portable. And the chairside diagnostic software aspect is very interesting. So that's one aspect to ask about. I think scanners that are able to capture more information other than just the surface of the prep or the tooth are vital, particularly color scanners these days, because identifying the margin, as we'll come on to see a bit later on in the presentation, particularly if it's subgingival, can be challenging, and the more data you've got, the better. A lot of these scanners now also output, as well as in STL format, in something called PLY format, and that is a triangle mesh with a texture skin put on it. So the scanner is not only recognizing and capturing anatomy, it's capturing the surface texture of what it's scanning and the color. And the more information you capture, the better, particularly when identifying the margin, because when you get color and texture, you're able to differentiate between soft tissue and tooth more easily. So those are some pointers to look at. There are lots more, and we've got a lot to get through today, but hopefully that's helpful to you. If you want to ask questions at the end, please feel free to do so. And also, if you want to contact me after this presentation, I'm more than happy to field individual queries and help you with your choices. So now we're going to go on and look at chairside versus CAD, a lab software in CAD. And this is an interesting debate, but we'll have a quick overview of it and then hopefully give you some pointers. Just to say very quickly that anything that can be done in wax in the lab now can be done chairside in CAD. The software has come on a long way. The automatic design proposition is very good now. Contact points, occlusion, so on and so forth. So both ways the software is indicated. Inlays, onlays, crowns, veneers, bridges, implant-borne restorations, they can all now be designed chairside or in the lab. And here we can see some examples of implant-borne work with intraoral scanning. Ortho, as we all know now, can be done chairside or in lab. The software is there not only for removable aligners, but also for fixed bracket work, and there's full digital workflows now for virtually every indication. The last one being, of course, acrylic dentures, and even there now the manufacturing technologies are coming of age where we can digitally manufacture dentures. However, does it make sense to design everything chairside? Your chairside time has a particular value, a cost associated with it, and does it make sense for you to be spending your time trying to design complex restorations that do require a lot of manual input, or does it make more sense to be seeing and treating patients? Well, I offer the next set of slides just to help us have a think about that. These slides show the design of a partial cobalt chrome framework using lab software. And I would ask at the end of this whether you would think this would be appropriate to do chairside or not. So here we've got the scan. In this case, it was a scan of a model, but it might also be an intraoral scan. The first thing we've got to do is digitally survey the model to work out a path of insertion. Now, that's not an easy task to do on a touch screen. You need a mouse or some other form of input device to be rotating that model. So would you want to be digitally surveying models chairside using a touch screen? Once it's surveyed, you have to digitally block it out. Again, quite a fiddly process, because after you've blocked it out, just in the same way as the technician would do in the lab, you have to carve into the undercuts using a mouse or some form of haptic or 3D input mouse device to provide the undercuts for the clasps. Again, in 3D, you need two hands, one on the keyboard and one on the mouse, or one on the haptics device and one on the mouse to do this design. And it's very fiddly and it's very accurate. And I don't think personally that it lends itself to a touch screen. Then you have to lay down the grid retention, again, a detailed process, and the plate itself to get the final object to be manufactured digitally. So I would suggest that those sort of technologies and applications don't lend themselves to chairside CAD, although it is possible. And in these cases, I would suggest that the intraoral scanner is primarily used as an impressioning device, and the data are uploaded to the cloud for the lab to download to work on offline. That's not to say for chairside immediate restorations, maybe temporaries in composite material or in nano composite material, that you wouldn't use the automatic design proposition of the chairside CAD to create a restoration and mill it chairside, so that the patient can go away with a restoration same day. And then you can also use the data that you've created there from that design to upload to the lab for them to design the definitive restoration and manufacture it in, for example, zirconia or Emacs. I think one has to ask oneself, does one want to be sintering zirconia or firing Emacs or lithium disilicate based materials chairside? The zirconia sintering process, for example, can take up to 8 hours. We generally do it overnight in big furnaces in our lab. Emacs crystallization takes about an hour. And then there's surface staining, glazing and finishing. And that's quite a long and fiddly process. And is that best to happen chairside or is it best to happen in the lab? I think basically a lot of technicians felt quite threatened by chairside milling. We don't see it that way. We actually see the more the digital technology footprint increases in the practice, the more workflow we're eventually going to see downstream in the lab, and that things should happen where they need to happen. So simpler manufacturing processes can happen in smaller desktop chairside milling machines, and more complex processes can happen in more expensive machinery, either in the local lab or in a national lab and production center such as ours. And just very quickly having a look at some of these designs to show how fiddly it can be. And again, I would pose the question, do we want to be doing those sort of things chairside, or do we want to be just capturing the impression chairside and letting the lab do those things? So as well as designing restorations, we can do image guided surgery. I touched on it briefly with the co-diagnostics reference to the Straumann Cares workflow. which is a fully open workflow, by the way, so you don't just have to place Straumann implants to do it. It can use any implant system. And again, surgical planning I would see happening in the practice. I think it should happen in the practice. And the brilliant thing about Straumann Care's co-diagnostic system is it has something called synergy, where you're able to plan the placement of the implants from a clinical perspective in the practice, maybe after you've seen and scanned the patient. And as you plan the placement of those implants, so in real time in the lab, we're able to see from the CAD restorative workstation where you've placed those implants, so that together as a team, we can come up with the optimum clinical and restorative plan for the treatment of the patient. And this slide here shows a fenestrated surgical guide for the placement of 2 lower anterior implants. And this is the synergy. Once you've done the CAD design, the treatment plan, we can have the CAD design, we can pre-manufacture the provisional restoration, we can pre-manufacture the custom abutments, and all of this can be ready so that you can place it all in one visit. Very quickly, as well as CBCT scanning and intraoral scanning or optical scanning of models, there's a third scanning modality coming of age, which is optical facial scanning of the patient, generally using a smartphone, iPhone, do it. Android also have the apps. They're all open. They output in STL data, and you can get 3D color scans of a patient's face, which can be merged with the other 2 scanning data, so that you can show the patient chairside how they might look if they have the treatment done. You can communicate the treatment plan easily to the patient, and you can sell the treatment plan to the patient. Now, one of the modalities we're seeing quite a lot of is where people will scan a patient chairside with an intraoral scanner, just ask them to pop out into the waiting room for 5 minutes. The data will go up into the cloud, back down in our lab. We'll do a virtual diagnostic wax up, smile design, upload that back through the cloud into chairside, and you can call the patient back in and then show them in color, in 3D, how they will look if they have the treatment done. And that is extremely powerful communication and sales tool for the practice. So I think we're going to see a lot of more of that modality, but I don't want to dwell on that. We do have other modules on digital dentistry and chairside milling and 3D printing in this series that you can find out more about those technologies. So next point to come on is scanning technique. We are about 2/3 of the way through now. So there is a way that most scanners work, and a preferred scanning technique. Every scanner is different, and normally at this stage with this lecture, I would get a couple of scanners out and let people have hands-on with it, because really it's the only way to learn. But just very briefly, for the purposes of this webinar, I'll run through some common issues with scanning and scanning techniques and how we can improve our scans. So for all scans with these kind of periscope-based devices, if we're doing a full arch scan, typically we start on the molar, and the scanner is typically positioned on the mesial distal axis, with the tip of the scanner pointing towards the distal. And the axis of the scanner follows the curve of the arch. And you can see fairly easily here good and bad positions. Obviously, the one on the bottom left here is physically impossible if the patient doesn't have a flip-top head. But you get the idea. Now, you can rest, typically with the scanners, you can rest the tip on the surface of the tooth. Remember, with the projected light scanners, they have a depth of field, so the distance between the wand and the object being scanned is important for the accuracy of what's being scanned. So That's one way to do it. The other way to do it is almost hold it like a handpiece, and use the second or third finger to rest on the patient, or on the chin of the patient, or on another tooth as you're scanning around, just to stabilize it. Obviously, if you've got handshake at all, that's not going to help the accuracy of the scan. It will take longer for the scan to take place, and the scanner will have to capture more data, more images, to eliminate the measurement uncertainty caused by the movement of the hand. So a nice steady hand, the correct focal depth are the way to do it. Now, that typically people move around the top of the arch, and then they just roll over the arch as they're moving around. The particular point that a lot of scanners get tripped up with is scanning the lower, particularly because of the collection of saliva, but also as they come around the 2s or the 3s, they all seem to have this issue where they slightly misstitch the data. And one of the challenges with intraoral scanning is obviously the probe, as you can see down the bottom here, has to be of a certain size for the patient's comfort. But in doing so, it only gives it a certain window or viewport, so that it can only capture in one view about 1.5 to 2 teeth, particularly in the molar region. And so whilst the scanner might be accurate to a quoted accuracy on that individual scan, as you move around the arch, the software is stitching all of the individual images together to create a composite image of the overall arch. And each stitching process in itself introduces a certain inaccuracy. So you've got an inaccuracy related to the hardware of the device itself, let's say 10, 15, 20 micron. And then you've got another error introduced by the stitching of the images as you go around the arch. So molar to molar, you might get a cumulative inaccuracy, which is greater than the stated accuracy of the device. So I think we have to look at that, and we have to be aware of that. It may be over 50 micron, 70 micron molar to molar. So we need to know what we're talking about when we're talking to people who are representing the scanners and coming to see you on Lunch and Learn. First point is the scanner in demo mode, which is why you're scanning in 10 seconds a full arch, or is it in full resolution mode? And if it's in full resolution mode, what is the accuracy of the recording of an individual prep, and what is the accuracy of recording of a full arch, molar to molar? Now, as you scan round, you'll see in a lot of these softwares, you can see it in the ITERO and others, the software realizes if it's made a stitching error and self-corrects it, particularly when you scan the opposing arch and scan the bite, and the upper and lower scan models are placed in occlusion. The software then is able, once it sees the models in occlusion, to work out where it might have stitched the data wrong and correct itself. You can actually see this in ITERO as you move around the arch. Sometimes you see the arch slightly compressed, and as you come around and it captures the other data, it kind of clicks out again. So let's remember that that data is interpolated, that's not recorded. The software is making a deduction there. And by the software making a deduction, of course, it's introducing a small error. So here's some scanning steps. This is from the Plan Mecca workflow, actually. Obviously, talking through the pre-op, the upper and the lower, and the buccal scans. The buccal bite scans, the more data you capture, the better. Because the way the software works is you capture one arch, you capture the other arch, you then ask the patient to bite together, and you do a buccal bite scan. And I would always, the more data you capture, the better the registration of the arches in occlusion. Because the way the software works is it picks anatomical landmarks on the upper and lower arch scans and relates them to the same anatomical landmark on the buccal scan. But because the buccal scan is only taken buccally and not over the occlusal surface, you don't have the advantage of the 3D correction of the stitching error. So you'll often find that the buccal bite scan is slightly compressed, and so that again that can cause a measurement inaccuracy. The more data you capture, the better is the basic rule of thumb. Obviously, softwares, this is again Plamatica, Romexis, they provide you with an immediate feedback. You know, one of the things to do is to reduce the saliva when you're taking the scan, obviously with suction, and also with dry pads which you can put in the cheek, and also using Optrogate is very useful for access, to make sure that you don't inadvertently scan soft tissue of the cheek, and you try and keep the tongue out of the way. A lot of the softwares now are intelligent in that they'll eliminate that, and they have automatic recognition of inadvertent soft tissue scan or artifact scan. The softwares all have an eraser tool, so if you do capture inadvertently things that you don't want, that the software is unable to automatically remove, you can remove it by hand. Sometimes you get double scans as well. I mean, we'll come on to talk about this shortly. And there's the active delete function. And it gives you some idea here of the processes that you have to go through during and after scan, and the software, how the software will help you to cleanse the data. Now the software, most of the softwares now provide real-time feedback. So if you've created a case for a patient and you've told the software that this is going to be, let's say, an Emax crown, it knows that you need a certain restorative dimension, let's say 1 mil. So once you've done the prep and you've scanned and you've put the virtual models in occlusion, the software is able to tell you whether there is an adequate restorative dimension for the indicated restorative material. So that's very helpful indeed to provide immediate feedback. The other thing to talk about very briefly, and I mean it's a huge subject, intraoral scanning, and we've got about 25 minutes to run, is implant scanning. And the way that works is that once you've placed the implant, you put in something that's like an abutment, but it's called a scan body. It's kind of light colored, generally made out of PEEK material, and B, so it reflects the light well of the intraoral scanner, and B, it has on the top of the scan body a known shape that the software is able to identify and triangulate with a library of shapes in the software. And from merging that data together, it's able to extrapolate back and calculate the subgingival position of the fixture head of the implant very accurately. So scan body scanning for implant-borne restorations is a common part of the workflow, and each different implant system has its own scan bodies. But these are all open systems now, so you can load the libraries up into your software and get that over to your lab for processing. The other part of intraoral scanning, which is a really important one to think about, is, and we touched on it before, is margin recognition, whether automatic or manual. And in the earlier days of intraoral scanning, the whole scan itself was just exported. And, you know, if you've got a subgingival margin, use retraction cord, the data sent off to the lab. But of course, the lab then would have to try and identify the margin in abstract. And this can be very difficult to do, particularly in the early days of monochrome scanners. So a lot of the chairside softwares now, and have done for some time, allow you the opportunity to identify the margin yourself. And that's really, really useful because it provides a great pointer to the lab before you transmit the data. And it avoids any error in margin identification. And again, if you can't identify the margin chairside, then maybe you want to revisit your scan before you transmit it. And much better to do that whilst you got the patient in the practice than having to call the patient back for a second scan appointment. And we can see here some of the tools. So I do think it's appropriate to identify margin in chairside software. I think that's a very useful function, but the automatic proposition in a lot of these softwares now is very good, and it's just a case of you validating what the software's identified as the margin before transmitting it, and maybe making a few minor alterations as we can see here. So that's scanning technique. Now we're going to look at some common issues with intraoral scanners, and we have touched on some of these already. Excuse me. So let's have a look. First issue is missing scan information. Now this can happen just because you haven't fully scanned an area. It can happen because saliva's got in the way. It can happen because the object being scanned is very reflective, gold crown, for example, or a non-precious crown that's highly polished. All of the softwares provide a real-time feedback of the scan process. So you're able to go over the scan area again. Most softwares offer a highlight of that to give you the option to auto-fill and stitch, which the software will do. But remember, it's guessing, it's interpolating the data, or to rescan that area as necessary to patch in some additional data to fill that missed scan data. I must say I prefer the concept of the software telling you where the scanner's missed areas and giving you the option and feedback to rescan those, rather than just automatically stitching it. And in some solutions, this is, you don't have the option, it just does it without you seeing it. So you don't know what's interpolated data and what isn't. And in other systems, it's an option, and in other systems, it does ask you. So I think, again, when you're looking for software, I would always like to know exactly what data my scanner's really capturing, and what it's interpolating. So, but that's common to all devices. Again, artifact caused by saliva or soft tissue, quite common. Double scan like that. So again, you would basically try to make the environment as dry and clean as possible. Use the obfuscates, and if you see a double scan like this, you're able, usually in the software, almost like replaying a video, to wind back to the point prior to capturing that false registration and then move forward again with the scanning. Or you can lasso that data, erase it, and then just rescan and patch in that area. So again, real-time feedback of scanning, really important to get a good scan. Misalignment to the bite scan, that is quite common, and obviously what we've already discussed, capturing sufficient buccal data for the maxillary and mandibular scans, so that the software has more data points to align during the bite scan. We do find bites and the restorations, occlusion, sometimes it can be high, so we need to be particularly vigilant on our bite registration scans. Indeed, some of our clients will take a intraoral scan, and then they'll take a wax bite and send it to us for scanning, because of some of the buccal bite scan issues. And I'm sure various vendors will have opinions on that, but one of the challenges we always find with any intraoral scanner is a misalignment of some sort in the bite scan, which subsequently might cause problems with occlusion. So just looking at quickly at some of the issues, and to summarize that, here's an example of an intraoral scan data. This is a few years ago now, it's 4 years ago, and this was a monochrome scanner. Obviously that's the intraoral scan data, and you can see some of the occlusion there highlighted on the lower image. We also, in this particular case, because we were trying to compare classic impressioning of the same case with intraoral scanning. So we got a impression of the same case, and we scanned the impression, and we also poured models and scanned the models so that we could compare the measurement errors that were introduced at each stage of the workflow. And we can see here the model dye and the IO scan. And if you look at these, it's very difficult to see on this screen, but you will already see that the impression has captured some data on the surface of the prep that the software has smoothed out in the IO scan, where the IO has been interpolating or smoothing data. And you can also begin to see what's going to happen in the next couple of slides, where it gets quite difficult for the lab to see where the margin is. And again, here we need to make sure we've used sufficient retraction cord. And this is in the days when the margin wasn't captured or validated chair side, so it was entirely left up to the lab to do. That was challenging before color and margin recognition. And you can see some of the reasons why that's occurred here. I won't go into these particular sets of slides in detail, except to say that certain anatomies have caused the software to miss the trough created by the retraction cord and smooth over that completely. So the lab's really got a challenge to identify where that margin is. And again, from another angle.
Very much for that. A very illuminating lecture on intraoral scanners. If you'd like more information or are keen to pursue intraoral scanners, there's a new service being offered by Ed called mynew.io, which you can learn everything about scanners. Thank you for attending our presentation today.